healthcare professionals. If you are preparing for EDIC Part 1, you are at right place. I will be discussing several high acuity questions pertaining to EDIC Part 1 in this video.
Question 1. A 60-year-old man, post-cardiac surgery, is on UFH for thromboprophylaxis. On day 7, platelets drop from 220,000 to 70,000. He develops new digital ischemia and a pulmonary embolism. Labs: PT 13 seconds, normal. APTT 32 seconds, normal. Fibrinogen normal, D-dimer mildly elevated. Which of the following is the most appropriate management? Stop heparin, start low molecular weight heparin. B. Stop heparin, initiate argatrobin. C. Continue UFH and transfuse platelets. D. Supportive care and plasma exchange. Restart heparin after platelet recovery. Correct answer is B. Stop heparin, initiate argatrobin. Explanation: this is heparin-induced thrombocytopenia, HIT, type 2, as manifested by thrombocytopenia, thrombosis, normal coagulation tests. DIC would show prolonged PT, APTT, and low fibrinogen. Management: stop all heparin, start a non-heparin anticoagulant like argatrobin, bivalirudin, or fondaparinux. Question 2. A 42-year-old woman with untreated Graves' disease is admitted with fever, agitation, atrial fibrillation, heart rate 160, and hypotension. Labs: TSH suppressed, free T4 markedly elevated. Which of the following is the correct sequence of therapy? Radioiodine, beta blocker, corticosteroid, propylthiouracil. B. Propylthiouracil iodine solution, beta blocker, corticosteroid. C. Beta blocker, propylthiouracil iodine solution, corticosteroid. D. Corticosteroid iodine solution, propylthiouracil, beta blocker. E. Beta blocker, radioiodine, corticosteroid, propylthiouracil. Correct answer is C. Beta blocker, propylthiouracil iodine solution, corticosteroid. Explanation: thyroid storm treatment sequence. Beta blocker, heart rate control. Propranolol reduces T4 to T3 conversion. Propylthiouracil blocks hormone synthesis and peripheral conversion of T4 to T3. Lugol's iodine block the release of thyroid hormone and should be given at least 1 hour after starting antithyroid drug therapy. Steroids reduces T4 to T3 conversion. This may also be useful in preventing relative adrenal insufficiency due to hyperthyroidism and improving vasomotor symptoms. Question 3. A 60-year-old man with prolonged mechanical ventilation develops septic shock. Cultures from tracheal aspirate and blood grow carbapenem-resistant Klebsiella pneumoniae, KPC producer. Which is the most appropriate empiric therapy? A. High-dose meropenem monotherapy. B. Tigecycline plus meropenem, dual therapy. C. Ceftazidime avibactam plus or minus aztreonam. D. Colistin plus tigecycline. Linezolid plus cefepime. Correct answer is C. Ceftazidime avibactam plus or minus aztreonam. Explanation: for carbapenem-resistant enterobacterals, CR, ceftazidime avibactam is first line, covers KPC. Aztreonam can be added for metallo-beta-lactamase producers. Question 4. A 62-year-old man with metastatic prostate carcinoma presents to the ICU with acute onset lower limb weakness, urinary retention, and hypotension. On exam, he has flaccid paraplegia, areflexia, and sensory level at T8. MRI spine shows an epidural mass compressing the spinal cord. Which of the following is the most appropriate immediate management? Start high-dose intravenous dexamethasone and arrange urgent radiotherapy. B. Begin intravenous mannitol infusion and elevate head of bed. C. Start therapeutic anticoagulation for presumed spinal venous thrombosis. D. Administer intrathecal methotrexate and supportive care. Urgent surgical decompression without steroids. Correct answer is A. Start high-dose intravenous dexamethasone and arrange urgent radiotherapy. Explanation: this is malignant spinal cord compression, an oncological emergency. First-line management is intravenous corticosteroids, dexamethasone 16 to 24 milligrams bolus, then divided doses, to reduce edema, followed by definitive treatment, radiotherapy for radiosensitive tumors like prostate or breast, or surgery if unstable spine or unknown diagnosis. Mannitol is not useful. Anticoagulation is inappropriate. Intrathecal chemotherapy is for leptomeningeal disease, not cord compression. Surgery alone may be needed, but steroids are always initiated. Question 5. A 40-year-old man with refractory B-cell acute lymphocytic leukemia is admitted to ICU after receiving CAR-T cell therapy. 12 hours later, he develops fever, 39.5 degrees Celsius, tachycardia, hypotension requiring norepinephrine, hypoxemia, and rising CRP and ferritin. Blood cultures are pending. Which of the following is the most appropriate next step in management? Broad-spectrum antibiotics and wait for cultures. B. Administer high-dose corticosteroids as first-line therapy. C. Immediate administration of tocilizumab, anti-interleukin 6 receptor antibody. D. Start plasmapheresis for removal of cytokines. Escalate vasopressors and avoid immunosuppressive drugs. Correct answer is C. Immediate administration of tocilizumab, anti-IL-6 receptor antibody. Explanation. This patient has cytokine release syndrome after CAR-T therapy, mimicking septic shock. Key features: high fever, hypotension, hypoxemia, elevated ferritin. Tocilizumab is first line for CRS. Corticosteroids are second line, as they may blunt CAR-T efficacy. Antibiotics are usually started empirically, cannot exclude infection, but definitive CRS treatment requires tocilizumab. Plasmapheresis not used in CRS.
Dear EDIC aspirants, I hope these questions were useful to you. If you have any feedback, suggestions, or comments, or if you have any doubt about any question or answer, please write down in the comment section where I will respond.